randomly selected HumanDx case that David is going to discuss. So, this is a case of a 17-year-old male with new onset seizures. The HPI is like that. These were tonic-clonic seizures, but there was no history of previous seizure activity. They last about 15 minutes and resolved when he presented to the emergency. His mother reports that there was urine. The patient is in post-ictal state on examination. Mother also notes recently referred to a child psychiatrist for tantrums and falling grades since starting his sophomore year of high school 6 months ago. His teachers report he's staring out of the windows during class and arriving at the wrong class for that period. He was previously a HANA student with no significant behavioral problems. Social history, he lives with his mother and father. There's no recent significant changes at home or school. Parents deny any concerns about alcohol or any other illicit drug use. Yeah, that's a complaint and HPI.
Thank you, Joseph. So, I'm not sure if that was my internet breaking or if it was yours. So I heard this is a 17 years old male who presented with, I think, the first episode of seizures, which lasted for about 15 minutes. So coming to the HPA, if you can come again quickly so I can pick some helpful pieces of information. So Upendo is Joseph has no slides today, so he's just reading, I think, from his device, but no slides.
Okay, I'm repeating the HPI. These were tonic-clonic seizures, no history of previous seizure activity. Last, his mother, patient is post-ictal
Joseph,
stage.
I'm not sure. It's probably my internet. Maybe is everyone else hearing Joseph clearly? You are breaking at some points. So some points it's clear. Sometimes it's not very audible. Breaks down at some points. If you can
Okay.
come again.
Am I audible?
Yes, I can hear you.
Okay. So the HPI is like that. They were chronic seizures, no history of previous seizure activity. They lasted about 15 minutes and they resolved by presentation to the emergency. State when he arrived at the emergency. Mother also announced recently referred to a child psychiatrist for temper tantrums and for since starting his sophomore year of high school.
So that previous point was
during class.
that previous point was the mother. Did she refer? Did she take the child to a psychiatrist, or can you come again
Yes.
on that?
Yeah, he recently was attended by a psychiatrist and due to temper tantrums and falling grades.
Okay. Yeah, you can continue from there.
Yeah, also his teachers are reporting that he's staring out of the windows during class and arriving at the wrong class for that period. He was previously a HANA student with no significant behavioral problems. He lives at home with mom and dad. No recent significant changes at home or school. Parents deny any concerns about alcohol or illicit drug use.
Yeah. So is that all, Joseph? Or is there something else? Because you broke again at some point.
Yeah, that's it.
Okay, so I'll start with these pieces of information. So a 17 years old male with the first ever seizure, and I'll try and summarize because I think my goal here is to get to the end and just learn from the case resolution because I'm not with most cases, I see some light right from the beginning. But with this one, I think I'll have to see how things go. But so a 17 years old male with the first ever seizure, and then this patient, there seems to be some behavioral issues that are also coming up, like the temper tantrums that are reported, and then the issue of falling grades at school. The question is whether it is because of behavioral issues, or there is also or there is cognitive decline in the child. So those are the questions that I have. But starting with the seizures, so the tonic-clonic seizures, and I believe, if I heard clearly, at some point this patient presented with was it urinary incontinence? So basically, we are talking of a generalized tonic-clonic seizures. The patient was
Yeah.
in a postictal state when he arrived at the emergency department. So we are talking of a true seizure. And I think it was not long ago we discussed a case of a seizure here in a female. I think a few months after delivery, which turned out to be venous sinus cerebral venous sinus thrombosis. So for this child, I'll say 17 years old, the first ever seizure, and then this seizure is coming with generalized tonic-clonic seizures, and then we see some behavioral issues, and the patient is having anger tantrums. They are falling grades at school. I think the other thing that, Joseph, you said is the patient was staring out the window during classes. Was that correct?
Yeah. Sure.
Okay. Yeah. So uh, my thinking now is I'm thinking of something that is going on with this patient. So I will wait until physical examination to hear if there is any clue. But at least from the history, we do not hear anything. But so the way I would think about it is, so this seizure could be seizures in general could be, you could be talking of about you could be talking about something that we can term a primary seizure or epilepsy. So you do imaging, you do other investigations, you do not come up with any structural issue. You do labs, you do not come up with any metabolic issue that is causing the seizures. So you end up saying this is epilepsy. And of course, epilepsy can be due to secondary issues, but then persisting. So that is one. But two is the seizures could be secondary to something. So secondary to something like metabolic issues. I think we've discussed in the past about metabolic issues that can present with seizures or convulsions. So electrolyte abnormalities like sodium, whether hyper or hypo, uh, glucose, particularly hypoglycemia, and of course, when you talk of hepatic encephalopathy, uremic encephalopathy, they can all present with seizures or convulsions. So these are metabolic. But apart from metabolic, I think so others will be in the big umbrella of structural, structural issues, like if the patient has a tumor sitting somewhere in the brain, if the patient has another space occupying lesion in the form of an infection like toxo, a brain abscess, uh, neurocysticercosis. Uh, so all these can present with seizures, and I believe there are many more. But then, if you think about this, of course, this is the first ever seizure. But then, before these seizures presented, this patient started to present with some behavioral issues, some mood issues. So we cannot just say this is something metabolic that came today. Maybe the patient has hypoglycemia, or there was nothing that is pointing in the direction of an electrolyte abnormality. So that makes me think and consider conditions that can bring a convergence of generalized tonic-clonic seizures and some behavioral stroke mood issues. And it's hard to think about any particular at this point, but I'll see as the history goes. So if we have other components of the history, although we are told that when it comes to drugs, because yes, drugs of abuse can present with the behavioral issues that we just had, but they can also present with seizures. But we are told that the issue of alcohol and probably other drugs is not a concern for this child. So let's proceed if you have other components of history, or we go to physical examination and then investigations in order to see if I can make some progress.
Okay, thank you. So, since child was in post-ictal state, the exam is limited, but his vital signs: heart rate 117 tachycardic, blood pressure 100/60 normal, saturating 96% on room air normal. His temperature was 98.8 Fahrenheit. That's normal in centigrade. He was post-ictal with myoclonus and spasticity in all four limbs. That's the exam.
Okay, so discussing this, so there's myoclonus and then spasticity in all four limbs. The patient is in
Yes.
a post-ictal state. We've not heard about any interventions that were given, so let's just go to the labs and anything else that you have.
Okay, so the labs, um, starting with the drug screen, urine drug screen was negative. FUBA picture and complete metabolic panel were within normal limits. RPR was negative. HIV was negative. There was negative antibodies for HSV, West Nile. Also, there was negative tests for lead and mercury. They performed lumbar puncture after a negative CT. The lumbar puncture showed normal opening pressure, normal cell count, elevated protein, normal glucose, gram stain, and cultures were negative.
Okay, so most of the things that we hear here are unremarkable. So when we talk of a drug screen, a urine drug screen negative, which means the recreational drug levels in this patient are undetectable. So that removes the possibility that we could be dealing with drugs of abuse. And so examples are like cocaine. Cocaine is a drug of abuse that can present with seizures, and then you have others, methamphetamines and others, which can also trigger seizure activity. So drugs of abuse are ruled out. So a CBC is normal, and then a comprehensive metabolic panel. So a comprehensive metabolic panel includes liver enzymes and liver function tests, uh, renal function tests, electrolytes, and then your glucose and all that can go into a basic metabolic panel. So the metabolic differentials that I was considering, although I expressed my reservations right from the beginning, are also ruled out. And then, yeah, it was important to consider infections because there are infections that can cause meningoencephalitis and present with seizures. So herpes simplex virus is one of those, and the others that are mentioned like West Nile. So all these are reported to be negative. So Joseph, were these done? Was it serology? Or was it done in the CSF? Like, was it a PCR in the CSF? Can you come again, Joseph?
West Nile. I think it's the CSF because I don't believe they do this. Yeah, I CSF.
Can you come again?
Oh, hello,
Yes, Joseph.
hello, David.
Yes, I can hear you.
Can you hear me?
Yes.
Yeah, I'm saying it's a CSF.
Okay, so those were done in the CSF. Yeah, so in the
Yes,
CSF,
they are the HSV and West Nile.
okay. Yeah, so those are nucleic acid amplification tests or PCR, which are pretty sensitive when it comes to if you want to rule out those infections. So what is remarkable? Yes, I think an RPR was important, although we do not know about the sexual history of this patient, but it's important because syphilis can present anyhow. And then HIV negative, so immunosuppression can come with a lot of things that can present with seizures. I talked about toxo. I talked about so other examples are like primary CNS lymphoma. They can also come with seizures. So HIV is negative. So what's striking, and maybe Joseph, I'll need you to come back again on that. But what I remember is that so in the CSF, the only thing that was remarkable was CSF protein, right? But cell count and all other parameters were unremarkable, right?
Yes, that's true.
Okay, so only CSF protein. So there is one terminology that I remember distantly, and that we call it's called albuminocytologic dissociation. So most of the times, particularly with infections, when you do CSF analysis, what you see is there are some changes in protein, which is commonly elevated, but you also see some abnormalities in the cell count. So you'll be told, for example, you have a lymphocytic pleocytosis or neutrophilic pleocytosis. So you have an elevated CSF cell count, which can predominantly be lymphocytes in issues like viral infections, like TB, and then neutrophils, for example, with acute bacterial meningitis. But cell count in this CSF is normal, but you have elevated CSF protein. Now, I'm not sure if an idiopathic seizure can present that way, but a few things that I know that can present that way, some inflammatory or immune mediated conditions. So notable examples are like multiple sclerosis, and then I believe the same can happen with neuromyelitis optica spectrum disorder, as well as myelin oligodendrocyte glycoprotein associated disease, or MOGAD in short form. We know it that way. So inflammatory conditions can present that way. And so if I talk about inflammatory conditions, I also need to consider malignancies. Although I do not have that information at my fingertips of whether malignancies can also present that way without causing an elevation in cell count. Because if we are talking of a leukemia, for example, maybe the cell count would be abnormal. But with these immune-mediated diseases, a few examples of which I've given, I think they can present that way. So that is what I pick. So uh, have I made some progress? Not very much. So we've ruled out metabolic issues. We've ruled out drugs of abuse. We know that this patient is not immunosuppressed from the angle of HIV. We are not sure about other causes of immunosuppression, but a comprehensive metabolic panel is unremarkable. So that was the remarkable finding, that the patient has elevated CSF protein. Opening pressure is unremarkable. So you have opening pressure would be elevated in conditions. You talk of meningitis, but also with idiopathic intracranial hypertension can also present with elevated opening pressure, but we do not expect the CSF protein to be elevated. So I think, and of course, I should be careful here to say that this is because I'm very limited when it comes to what is going on in this particular patient. But I think this takes me in the direction of some inflammatory stroke immune mediated conditions. But then we have not had anything from the history that is in keeping with these diseases, although we know some of them can present with can present purely in the CNS without involvement of other organ systems. But then we are told that CT scan, brain CT was done and was negative. I'm not sure if we'll have some other sort of imaging, which of course, if I was attending this patient, I need to do a brain MRI seizure protocol and see if I can see anything. So, if, talking of immune-mediated conditions, you'll see some hyperintensities and some other findings. So I think I need imaging, proper imaging, to see what is going on. But any other pieces of information, Joseph, if you have any, give them to me.
Okay, thank you. That's a good progress. So let's present the imaging. There is an MRI here. It shows decreased gray matter volume within the frontotemporal cortex, amygdala, and cingulate gyrus. And then they did an EEG, which showed bursts of high voltage complexes of 2 to 3 per second delta waves and sharp waves. These complexes last about 0.5 to 3 seconds and occur every 3 to 20 seconds. Each complex is followed by a relatively flat pattern. Back to you.
Can you come again on the MRI as well as the EEG?
MRI shows decreased gray matter volume within the frontotemporal cortex, amygdala, and cingulate gyrus. EEG shows burst of high voltage complexes of 2 to 3 per second delta waves and sharp waves. These complexes last 0.5 to 3 seconds and occur every 3 to 20 seconds. Each complex is followed by a relatively flat pattern.
Okay, so I won't even try to discuss the EEG because even though I remember a few of what you've talked about, like sharp waves and all that, but I'm not an expert in EEG interpretation. And of course, I know that that can be an important signal that leads me in the right direction. But then I'm limited in that. But so with regards to the MRI, the patient has reduced the patient has reduced gray matter volume in the frontotemporal as well as cingulate gyrus, if I remember correctly what you said, Joseph.
Yeah.
Yeah. So this is a 17 years old child, 17 years old male, and then they are presenting with reduced gray matter volume in those areas. So I won't pretend like I know what is going on, but a few things come to mind again. Uh, Medicine being very wide, you read about some things, you forget many of that, especially when you do not encounter them on a daily basis. But so I'll think out loud. The first thing that came to mind when I heard about reduction in volume of those areas was, this is a 17 years old. How do they? How comes they have a degenerative disease? degenerative CNS disease. So, because that is the picture that I have, that if someone presents, so we expect to see that commonly in the elderly, that you have an elderly person, they present, you have an elderly person and then they present with memory loss, for example. They can have some motor symptoms, so cognitive symptoms in general, as well as mood symptoms. They are irritable, they are depressed sometimes, they cry for no reason. Then part of the things that you consider degenerative diseases, frontotemporal dementia, for example, and many others. But then this is this is a 17 years old, and I have never read about it, whether it's a case report or from a book or any case among the cases that I read and solve online. I do not remember reading about a degenerative CNS disease presenting in a 17 years old. So that was one of the things that I was thinking about, is this degenerative disease. But something else that came to mind is the patient presented with seizures, and then with some behavioral issues, and then these are the findings that are seen on imaging. So another thing was temporal lobe epilepsy. But then, so temporal lobe epilepsy, again, I do not, I think I know very little about it. But temporal lobe epilepsy, what I know is the presentation is, it comes with it comes with specific aura symptoms. And then if we are just talking of temporal lobe epilepsy, what explains the shrinkage in the frontal, in the cingulate gyrus, not just the temporal lobe, and then what explains the increase the CSF protein. So those are thoughts, and this is desperate because I have absolutely no idea on what is going on with the patient. But now, so I'll just try and represent this problem and see if I can come out with anything. So my goal now is shifts from getting the diagnosis right, because I think 99% chance I won't get it right, but then to see if in the big bucket, among the differentials that I'll give, maybe the specific diagnosis will fall within those categories. So a 17 years old male who presented with a first ever generalized tonic-clonic seizure with the typical symptoms of a seizure, including urinary incontinence, and they arrive at the emergency department. They are in a postictal state, and the examination, physical examination, confirms that the patient is still spastic, has myoclonus. But then further history reveals that this patient presented with some behavioral and mood issues, anger tantrums, as well as falling grades in a student who was an honors student previously. So physical examination limited, but we come to labs, many of them unremarkable apart from elevated CSF protein, and then imaging reveals shrinkage, reduced volume in the frontal temporal, as well as cingulate gyrus, gray matter. So even with that representation, so if I summarized this case to an expert who knows what is going on, they would give a diagnosis right away. But for me, nothing rings a bell. So all I'm thinking now is this could be an immune mediated disease because of the elevated CSF protein that we saw. But then the examples of immune mediated diseases that I mentioned earlier, like MS, multiple sclerosis, NMOSD, MOGAD, the age demographic I know that they can happen at any age, but they come with increasing age. And I did not hear the typical findings, for example, for MS, because MS uh, is a demyelinating disease. And so the typical, the textbook presentation that we know is that when you do imaging, you see some hyperintensities, periventricular hyperintensities, uh, which are finger-like. They are called Dawson fingers. So that is classical. So even when it came to imaging, the location of the lesions or the pathology that was reported was far away from what I know to present in MS. And then with something like neuromyelitis optica, we did not hear about a previous presentation like optic nerve involvement, or even with this MRI, because you do brain MRI. So if the optic nerve is involved, you could see hyperintensities in the optic nerve. So nothing like that is reported. So maybe there could be an immune mediated or an inflammatory condition of the CNS that I do not know, or among the ones that I've mentioned, that presents like in this 17 years old male, but I do not know that. So I'll be very happy to learn about that. So apart from that, if it's not those immune mediated, so basically which will lead to attack of parts of the CNS. And we commonly, what I know is that we would see hyperintensities which we have not seen. Uh, so we leave that. We open another bucket, which is uh, infiltrations. So infiltrations like deposition, these and I think I've read about some of those diseases which present even in the young, that you have deposition of some misfolded proteins or other structures in the CNS, and they could present with seizures, they could present with cognitive impairment, even mood abnormalities. But then I do not have any particular one that comes close uh, at this point. But that would be another big bucket. So deposition of misfolded proteins, all that. Degenerative, I think. I have this bias to think about to say that a degenerative disease would not present in a young child like that. But I'll be very happy to learn about that today, because the learning is endless. So apart from those, do I have anything else? I'm not sure. So at this point, so Antimon mentioned something here. That is mesiotemporal sclerosis, mesiotemporal epilepsy. So I've heard about this, but then I do not remember anything about its presentation. So could be the diagnosis, could not be. The eyes can see what the mind doesn't know. So I'm not sure about that. So Joseph, if you have any other piece of information, I'm not sure if this is the point where I commit, or maybe there is another piece of information that can be helpful. So back to you.
Okay, thank you. And thank you, the chat. So there is one last aliquot. And yeah, so the doctors that were seeing the patient got into like they struggled as you're doing here. And then they further wanted further history from the mother. And mother said that uh, there is no recent travel, but this child was born in Burundi, and he didn't receive vaccination until he moved to the United States at age 3 years. That's the last aliquot, and you can commit to diagnosis if you have.
Okay. So this is a 17 years old, uh, and then did not receive routine childhood vaccinations and presents like this. So you tell me that the typical vaccines that are given during childhood, we have the BCG, which is for tuberculosis, uh, and then pentavalent in our setting, and then measles. Well, we do not get measles, mumps, rubella in our setting, so it's MR, measles included. So there's only one thing that comes to mind now, that in someone who has had measles, for example, there is this CNS complication of measles, which I do not remember the name correctly, but panencephalitis. I think panencephalitis is I'm not sure if there is the word sclerosing there, but basically it's something post measles. So someone has had measles in the past, and then they present with this, but so has the word panencephalitis in it. Thank you, Seba. So it's subacute sclerosing panencephalitis. Thank you very much. So that is what I remember about measles. So I think with that history of not receiving routine childhood vaccinations, that's the only one that I can relate. Because thinking about others like BCG, for example, we are not hearing any presentation here in keeping with tuberculosis, including TB meningitis. Because and again, yeah. So that's with regards to BCG, and then come to others like varicella, for example. Or varicella, the presentation will mostly be a cutaneous presentation and systemic, but I do not know of any CNS complications. So the only one for which I know CNS complications is measles, and so that is the subacute sclerosing panencephalitis. So that could be the diagnosis, or I could be missing something else. So I think I should not waste more of your time, Joseph, uh, just sitting back and listening to learn.
Thank you very much. You're very intelligent, man. Plus, Seba is also very intelligent. And Roland, you guys, I solved this case and I missed. I didn't have a clue, but you guys are remarkable. Yeah. So, they also thought about SSP, subacute sclerosing panencephalitis, because of that history, and they sent serum anti-measles antibody concentration, which came back elevated, and they also sent CSF protein concentration and detectable anti-measles antibody were also elevated. So yes, the final diagnosis was subacute sclerosing panencephalitis, SSP. Very important case, especially to us, because I wondered if this patient presented to me. I would say epilepsy. This is the kind of patient you take them to a neurologist plus psychiatrist, but you miss something maybe you could have thought about. Um, they have some teaching points here. I think they're very important. We should review them. So the patient was admitted to the ICU. He was given supportive care and anti-seizure medications and antispastic medications. The pathophysiology is interesting. It says that this disease is fatal. It's a progressive degenerative disease of the central nervous system that usually occurs 3 to 20 years after natural measles virus infection. Its pathogenesis is not well understood, but may involve persistent infection with genetic variant of measles virus within the CNS. Okay, so the diagnosis is difficult in early stages. Behavior as a behavioral problem, personality changes, and academic declines may be the only manifestations, as it was 6 months prior to the seizure in this patient. But in later stages, the patient developed motor dysfunction, myoclonus, spasticity, seizure, and optic abnormalities. The final stage includes stupor, autonomic instability, and death. There is no specific treatment for this condition. So to prevent, it's measles vaccine when these are when they are key. So this child in Burundi should have received measles vaccine when he was born in Burundi. Yeah, so that was the case, David. Thank you very much.
Thank you, Joseph. I, I mean, so that final clue, I'm not sure. So if you asked me at the beginning, I wouldn't know if I would get this diagnosis right. And up to this point, I should say that it's the clues that are given, and the case it's because the case was is summarized. So basically, you are receiving information in terms of helpful clues, which are typically signals, and therefore uh, work becomes easier for you because it's processed information. So uh, my reflections from the case is so number one, there's a lot that I do not know, and even with what I've read and that I believe I know, there are still many gaps. And then something else is there's information that we come across that is very distant. So if I believe everyone in the call was paying attention. So after the issue of childhood vaccination was brought up, uh, it came by pattern recognition as a reflex because it's something that I've read about. I did not remember it completely and I had to get help. So again, thank you very much, Seba, because I remember the word panencephalitis, I remembered sclerosing, but I could not remember the full form. So I think that is the that tells me the importance of the routine reading that we are doing. That yes, we see patients, we focus on the cases that we encounter on a day to day, but then reading, whether it's by hearing a case or reading about a case, and then you are just reading randomly, you have this information uh, that is not very properly stored because, again, as you could see, if if I had the details of subacute sclerosing panencephalitis, I would have thought about that differential right from the beginning. But it's a clue about vaccination that triggered the memory, which again was hazy and distant, but the information came up. So that reminds me the value of routine reading. So those are reflections for me, but overall, a very interesting case. I learned a lot from the case and I struggled a lot. So thank you very much, Joseph. So not sure if the chat uh, a few issues, but very helpful. If there is anyone who has anything, whether you have a question, a comment, or any experiences to share, because there could be someone who has encountered a case or maybe suspected or read about a case like this, please unmute and speak. And Antimon, if you're in a position where you can speak, maybe you can teach us a bit about mesial temporal sclerosis. So anyone with any issues, including Antimon, please welcome. I'm not seeing any hands. You can just, if you have any issue, if you have anything, you can just unmute and speak. Okay, I'm not seeing any. So Joseph, I believe some people who have joined this call, it's their first time. So maybe you can tell them a bit about HumanDx, which I should start by saying HumanDx and AfroDx are not the same thing. So it's HumanDx is a bigger project which we are not related. Is completely unrelated to AfroDx. So Joseph, you can tell them a bit about it.
Yeah, so this is a free app that's available both in Android and SOS. So it's for people like us here who loves diagnosis. So it's the people going like this case, they share real cases and you go and solve them, because as you see, reading just a case is not as helpful to you as trying to actively solve it aliquot by aliquot, the way we do here by presenting. So they will give you, like I was doing, they give you an aliquot, and then you think at the end of the day you have to put your diagnosis, and you can get the diagnosis right or wrong, it doesn't matter. Then they will give you the diagnosis and they will give you the teaching points. Super helpful, because look at this case, for example. um, it- Very relevant to us, because people who are unvaccinated are available in this country, in this region, and they can have a disease like this. So by seeing the case like this, it's like you have seen the patient, like so it clicks in your mind, like, David, today we have amplified, or we have like resurrected his maybe basic science knowledge of SSP. um yeah, so that's it. I encourage every one of you, if you don't have this, go on your on go on your phone and search HumanDx. You download it and you start solving case. I do solve at one case per day on most days, so pretty much helpful. Yeah.
Thank you, Joseph. So, again, the same call. We need cases, we need discussants. So, if you have any, please reach out. And the chat on WhatsApp is open. So, if you have any issues to share there, you're free to share them. Otherwise, if there is nothing, because I do not see any hands or anyone unmuted, if there is nothing else, it was good having you around. You people are very committed to learning, because you could be watching some soccer matches right now, but you decided to be here. So congratulations. So have a good night and see you next weekend.